Afternoon and welcome to EFCCA Patient Talks. This series we have a very interesting topic on seasonal vaccinations and IBD and the effects for patients on the seasonal vaccinations. We're joined today by a number of speakers who will give different points of view and a lot more education on the vaccinations. First of all, we're delighted to be joined by the Global Actions on Patient Safety, which is Kaldeep Saini, who's will talk us through what in relation to vaccinations, and especially more so the seasonal vaccinations this year, very much so on the influenza and pneumococcal vaccinations besides the COVID-19 vaccinations. So Dr. Salmi, I would like you to join us and take us through your presentation.
Thank you very much. I will be very short and brief on the introduction side. So I will just like to introduce where we are in just 4 slides, and then I will take on the key issues. We are pushing forward the Global Patient Safety Action Movement. Can you next slide? And what we have said is nothing about the patients without us. Second is we 21 years of age this year, and it's what a coming of age, you know. I mean, nowhere in our entire history have we ever experienced this, and it's a devastating turn of events. Second slide, please. Also, we are at the same age as the first report on to err is human came out about talking about patient safety to build better healthcare systems and safer systems. And I suppose now everybody is talking about build back better. It would be nice to see how we can now build back that better and safe healthcare systems. Next slide. We are about 300 members, 71 countries, 52 disease areas, and we are reaching approximately over 1 million patients directly. Indirectly, the numbers are larger to various patient groups and various organizations. Next. Our 3-pronged strategy really is to empower, drive, and shape the law and policy in practice and drive towards patient-centered universal health care globally. And let's not forget that we still have to deliver that in 10 years. Next slide. WHO has defined patient safety as an issue which is about healthcare that has emerged in evolving and complexities, and therefore patient harm is happening in care facilities, be it in the vaccination programs or medication errors, harm due to other issues. But the cornerstone is of WHO's patient safety is really about continuous improvement and learning from errors. I think that we need to keep in mind in this seasonal vaccination that's been going on. We have over 10, 20 years of seasonal vaccination of vaccinating vulnerable groups, and we have learned everything from those that we have. And the health authorities that have maintained this vaccination programs will be in a better shape to then go with the COVID, I think. So we have got that requisite knowledge in our communities and nursing staff available. Next slide. We knew that the top 10 errors that we make in vaccination or any other program was really about medication errors. So this is going to be very interesting what happens, you know, when you've got flu vaccination, MMR, and COVID vaccination, 3 all sitting on their table. Do we make any errors? Yeah. How many doses and what's up? Then second, very worrying was healthcare associated infection. I think you also how this has really gone way out there. People are now really considering this seriously in that your health systems have become in places where you get infected with COVID and others. Unsafe surgical care procedures, which we knew, and then unsafe injection practices, I think, are the big ones that we will have to look out for. Next slide. Our burden, I think, our belief is that if you want to take on this whole safety of vaccines, we must look at the WHO's a global action on vaccinations and global action on patient safety, and be part of that universal health coverage. Next slide. Right. We have said that we need a safe universal health coverage and we need evidence-based co-creation in all elements of this. And last slide, please. One more. And as you said, we mark World Patient Safety Day on 17th September each year. And it's important that we reflect on vaccine safety in that year. And one more slide, and that's it. Yeah. And the aim for this next decade of patient safety is zero harm, and we must look at that. So I'll end the presentation there and now just discuss the main points that we feel as patients. We know that from historic importance that our patients have been quite used to that the flu pandemic, flu epidemics that break out, seasonal flu, do bring severe stress on our health systems, our own health, and many patients with immunocompromised systems and breathing health systems have really suffered. And we have encouraged this uptake of vaccinations because it's very important to relieve the burden. So we were really relieving the burden already historically. And we are very good at that. I think from our COVID-19 surveys, when we asked people, would you be undertaking some of the protective vaccination projects, they says yes. We're already doing the seasonal flu. We don't mind going in there having that one extra vaccination shot. Second, we know that the COVID vaccination is almost here in that we've got various candidates, but we will have uphill task to ensure that we get that correct information out. The infodemic surrounding this particular COVID-19 vaccinations already started, and to some degree, I think some of the research pharmaceutical companies have been slow in ensuring they've engaged patients in the center of communication, because as you saw, one vaccine has already started raising questions that, oh, they're partial results, we need more results. So we must do a thorough job. In order to inspire confidence, we must make sure that the regulators really have a great look at this, and we ensure that all the vaccines passed us must make sure they are of the quality safety indication we need. And more importantly, we have the pharmacovigilance that we require from them. Then the issue of what comes up next is that we have noticed that to a larger degree, access is a big issue. Many economies had slowly mothballed their vaccination programs when they eradicated polio or eliminated polio in most countries. And then they had taken off other conditions, and what they were now looking at was slowly looking at TB, cholera. All these were now put into what I call sporadic vaccination. Ebola again. So, but there are some countries in low and middle income countries where I'm very glad to say, like for instance, India, Pakistan and others, that they still have an infrastructure present there with a cold chain intact that can be used quickly. And I'm very hopeful that these countries will jump back better. In Europe, what we have seen is that because we invested a lot in our primary healthcare, I think from the Astana summit 2 years ago, we realized that investing in primary healthcare was very good. After Alma-Ata, this was the next move, that primary healthcare was where we needed. This being the year of the nurse and midwife, I noticed ICN was really pushing forward nurses to come forward. And I think the nurses have done a great job in coming out of retirement. And I was so surprised yesterday. I spoke to a group of 5 or 6 nurses who were present when smallpox was eradicated in Africa. So you can imagine they're coming out of retirement a second time. It's so nice to see that these are nurses who have come back. And it all says that you can never retire if you're a nurse. You get my meaning on that. So they're coming back into this program. So we'll have to see them. Patients generally are supportive of vaccination programs, and they would like to be amongst the first. And I think we were recommending that let us get the vulnerable groups first. If there's an order of precedence, it's health professionals first, making sure those who are exposed up front, and then have vulnerable patients second. That will make sure that we can ease their shielding and engage them back into the society. And then we can then take on for the rest of the community, senior citizens, obviously following on, somebody else will cover this, and then the rest of the population. So we are recommending that order. If there is a supply issue in place, that let's make sure that happens. What will be more important is lastly need to bring in the issue of maintaining. If there are 2-dose, 3-dose solutions, we'll have to really make sure our records are up to date. Make sure those booster shots are received. So health informatics needs to be strengthened up. And more importantly, we are also suggesting one more. I think many of you would have realized that we can't continually have Zoom calls in Europe to talk. We need to physically meet each other in places. So therefore, if there's a blue certificate rather than the yellow fever, if you have a blue certificate in place, that will be really helpful to us, both to get the travel insurance we need, plus also we don't have to continually go into isolation every time we move borders. So that will really help us get Europe back and working together. And lastly, I would like to say is that in this era of building back better, we are starting from the very basic point, which is making sure we have protective vaccination across a whole range of things, not COVID alone. Let's use it to make sure that the human papilloma virus is dealt with. If you have got vaccinations for MMR, which are already there, if you're looking at malaria vaccine as well for Africa, let's look at vaccination in total and use that protective element, because our health systems will not have money and resources to deal with the fallout if we are not vaccinated and protected. So we have to use primary prevention and protective programs now to relieve the stress and the money, so that we can take care of the other NCDs and other agendas that have been suspended over this COVID-19. I'll end at that, and you can now proceed on to the next. Thank you.
Thank you very much, Dr. Sami. I should have mentioned that if anybody has any questions, please put them in the comment box. There was a few, and just maybe 1 or 2 questions if you have time, Mr. Sami. I fully agree with that. We need to protect our health systems and obviously work together, and to get Europe back together would be fantastic. I know even within EFCCA, not seeing our members and not seeing fellow patients can be quite a struggle. When you look at, I suppose one thing that struck a chord with me was when you look at the healthcare associated infections, and if I park COVID-19 and just even look at the seasonal influenza jab, how can we assure patients that I suppose the benefits of any vaccination, once brought through the process, is better than not getting it?
Yeah. I think this is what when they had pre-surgery and pre-entry protocols, where you were taking swabs of various individuals to see what are the bacteria populations like, where are the likelihood. And I think we had introduced protective vaccinations there. So we actually were making sure sepsis doesn't happen. We were making sure vulnerable patients who are going in for major surgery were protected. I think we need to renew those programs back again. For what I call €1, €2 vaccine, we are really threatening the whole life cycle. I think we need to bring that discipline back. We have learned how to wear masks, keep that social distance, and wash hands. I think we will not be blasé about it and really ignore this. I think we need to all adhere to that health system. You need, when you're called in, I think it's a patient behavior change. If you're being called in for no surgery, of a surgery, you make sure you attend that pre-clinic to assess you, and then make sure you've got 2 weeks at least to build up that immunity, have that vaccination done. Very important. I think we need to look at those things. These are little things we'll ignore. I think now they're becoming big.
Yeah,
We need to bring back those.
How do you think, and I suppose if I look at media and press on the COVID vaccine, how do we assure patients that safety is there no matter what the vaccine?
I think this is, again, that there has to be a strong message, firstly, from the political leadership. I think we still got people out there who have got strange ideas about vaccination programs. Then, at the same time, the regulators, I think the democratic deficit that's happened. I think this is something that I was addressing this morning, that one of the biggest casualty of this whole COVID-19 was trust. We have basically lost trust in our politicians, who we didn't trust anyway, but now it's even lower. And we lost trust in our health system. And to build back trust requires a lot of effort. I mean, it needs a lot of different kind of communication, needs open forums. We need to re-engage all of our expert patients now. We need to be proactive. Don't be sitting there on the fence. Let's go get these trolls who are out there trying to spread the infodemic. Let's control them. Be the circuit breakers in their messages. Let's build back that communication. Then we in Europe are lucky in that we have got the European Medicines Agency. I think if there was someone, if there's an English metaphor to use, batting with a straight bat, then EMA has that respect throughout the world, and they've done a great job, and they haven't balked in their responsibility. They have said, we will, no matter how truncated you do this, how short the vaccine development is, it will have no impact on us evaluating it and giving this a go ahead. So they have no levers, which is very good signal to them. The last, I think, bit is really the anti-vaxxers or the vaccine hesitation. This will have to be dealt, firstly, as traditionally we have always, as a pluralistic society, and the European belief is proportionality, the proportionality in our behavior. We have to work with them on this. But if really, if the push comes to shove, patients, especially my patients who are shielded, are really getting really anxious that they're going shopping and there's nobody wearing a mask, arguing about this, about God's law on breathing air, to it's not mandated, it's illegal, arguing. They open up a legal center inside a shopping mall, law case. We need to then deal with these people through the enforcement authorities. We can't risk. We do have all the jurisdiction and laws, I think, especially with common law jurisdictions. We've got the 1888 Act here to deal with some of the infectious people, especially TB. We can actually detain them and do whatever we can. Okay. But that's not the direction we are proposing. But
no, absolutely. And I just have a question from a member. Is there some practices from other parts of the world on, I suppose, to deal with that reluctance and how to raise awareness and increase the acceptance of the vaccination program in general, not even just in relation to COVID?
Yes, I think this is what I had been assisting. As we are involved with UPATI, the European Patient Academy for on innovative research. And we had been saying for a long time, please, please, please engage patients very early on in the design of your research, and then communication and dissemination. And it's only yesterday we met with Young Geisler and Thomas to discuss that we have a Asia Pacific Patients Congress coming up, which is free for you, everybody, to register. Please look out for that. And we were discussing this session on that. And they said this business by one of the companies, I wouldn't name them, who have just been told to relook at their results. They should have engaged patients very early on in the dissemination as well. We would have told them how to disseminate this. But now, since that's not done, I think it now falls on us to use our social influencers who are there to build that confidence back in. It's a hard struggle. It's for our own. It's a selfish nature. I'm cancer patient myself, recovered. I'm pushing it for my own sake. I don't look at this as a social welfare task. I'm looking at it as for me. I'm doing it for me, although there are the altruistic outcomes of that. So let's push that thing in what I call national unity and global solidarity. Let's deal with this. And we are asking Facebook and Twitter now. They've already started this I don't know if there was a meeting yesterday with the chief medical officer of Google, who said they will not tolerate any anti-vaxxer rhetoric out there. Free speech is free speech, but they'll put them to task, I think, to check everything.
And I have one final question, Sami, because I know your time is precious for you. You mentioned there about building trust. How do we build the trust that if there is a part of the healthcare operators that are, I suppose, not getting the vaccines themselves?
Yeah, it's this has become very easy. So suddenly, something happened with COVID-19. That something's gone really great for us in that we can no longer ignore things. Health cannot be put in the back burner. There is no other way. I mean, look at the economic collapse around us. You see what's going on. I mean, I have yet to find one person who sees otherwise, that we don't need to change. I think that trust now has to be built from the ruins. It's a difficult one, but I think with early successes, I think if more patients come up and we exalt this, patients start getting back to work, resuming their careers. I love those holiday pictures. I want to be the first patient in Costa Rica bird watching, showing up recovered and built back better, So yes, we need to do that and bring back that normality. I think sense of normality needs to be brought back. But let's not forget, there is still a lot of things to be done. There is long COVID to be dealt with, because that's still coming up the back. We are seeing the early break of dawn, and let's make sure we do get that full sunrise sooner, and
Absolutely.
don't have any more eclipses of the sun, as I call it, along the way. Thank you.
No problem. Thank you very much. And thank you very much for joining us. And we look forward, hopefully, to meeting you again, and maybe face-to-face when Europe does come back together.
Yes, please. I promise to meet you guys. And please do join our Asia Pacific Patients Congress. And I'll send you the links.
Yeah, do definitely.
I need your European perspectives for Asian colleagues. I think we are the same. I think
we need to share. We need to share ideas at all times.
Exactly. And there are a lot of things that happen in Korea and in Taiwan. As you know, they will be the first to run out mass vaccination programs.
Yes, yeah.
And there you'll be surprised again. The uptake will be so high. They really have the public trust between them and the politicians is very high, and I think social responsibility.
But I think we often say that IBD has no borders, and obviously COVID absolutely does not have any borders either. So we look forward to working with you again and sharing information.
Yes, thank you very much, and I'll
Okay.
send the links over. Thank you, everybody.
Yeah, thanks a million.
Thank you, bye.
Thank you. So next, that was an interesting conversation, and probably I could have kept asking questions. So again, if you have any questions for the speakers, if you just put them into the comment boxes. So now we will look at the role of seasonal vaccinations for IBD patients. And Dr. Bogdan Mastoscu, the head of the gastroenterology department in Bucharest, will join me. I hope I got your name right.
Hi everybody. Thank you for inviting me. I will try to share with you to discuss some ideas on seasonal vaccinations and of course IBD because we are here. Can you put the first slide of my presentation, please? So it's a delicate subject because common sense tells us that there is not a good idea to mix an immunomediated disease like IBD and some infectious agents. But we already know that these things are mixed in reality in the real world because as you can see, for example, in this slide, the number of people getting pneumonia it's bigger in those having already IBD compared to the general population without IBD. So we know that between these two chapters, IBD and infectious agents, there are some links. These links are very complex, and we don't have the answers to all the questions. So, for example, we don't know if these two mix because there is some dysregulated immune response in IBD. Okay, we have some data on this, but not enough to be sure that this dysregulated immune response is impacting the sensibility to germs and to infections. Or it might be done, like in the next slide, to the drugs that we are using to treat IBD. And there are a lot of studies showing that using the so-called immunosuppressive drugs, like biologics, like thiopurines, like methotrexate, or even the steroids, or mainly the steroids, will increase the risk of having an infection. As you can see, this is true also for opportunistic infections. These infections are not happening in people with normal immunity. That's why they are called opportunistic, because they are made possible, but this dysregulated immune response or suppressed immune response because of the drugs. And using one drug, it's bad enough. Using more, 2 or 3 drugs, will increase the risk of getting an infection. And this is unrelated to the organ or to the site of the infection, because this can be located also in the digestive tract and also in the respiratory organs. Could you change the slide? So we know that using more drugs or some drugs is worse than using less. How can we define what is called an high immunosuppressive level, or it's a low or an acceptable immunosuppressive level? From practice, we know that using a high dose, daily dose of steroids, more than 20 milligrams of prednisone, or for a long time, more than 2 weeks, for example, using biologics, or even the consequences of the IBD, like the severe malnutrition. This all will lead to high level of immunosuppressive, so a high risk of contracting disease. Can you change the slide? Okay, having an infection is not a bad thing only on a theoretical level, but we know that having an infection in people with IBD will lead to an increase, a severe increase in the rate of in-hospital mortality. As you can see, even the most common infections will increase this risk of dying in the hospital for people on immunosuppressive treatments. So, can you change the slide? Thank you. We can think that knowing that some preventive disease could be stopped by using vaccination will lead to a high prevalence and a high acceptance of vaccination. But it's not true. This not happens in reality, because look, from one study, how many people with IBD were in fact vaccinated. Even if we speak about influenza or for varicella or from infection with the hepatitis B virus, we can see that not more than 1/3 of the patients were vaccinated. And the problems resides also on the medical side, because there is a continuous debate between gastroenterologists and GPs who should vaccinate people with IBD. Everyone thinks that the other one should vaccinate the people. But also the patients are not aware of the advantages brought by vaccination, or they fear the effects of drugs injected. And there is also a problem of availability of the vaccine. In some countries, some vaccines are not available, and you may want to get the vaccine, but it's impossible. Next slide, please. So a short description of vaccines used today. This list grows every time. But we are using live attenuated vaccines. So these vaccines contains an attenuated form of the causative germ. And this, for example, is used in vaccines against measles or rubella, or even in the anti-TB vaccination. And these kind of vaccines are the most delicate to use, because the germ, remember, it's alive and may cause unwanted effects through disease in people who are immunosuppressed. Then we have the inactivated vaccines, where a dead microorganism like the flu virus or the polio virus is used, or in some vaccines we are using only parts of the germ. It's the case of the vaccination in pneumonia, or in the case of hepatitis B. It's not a very dangerous vaccine, because the part of the virus cannot induce the disease, but only provoke the immune reaction, the immune response. And there are also vaccines using only toxin, poison from the germ. Of course, the most dangerous are the live attenuated vaccines. The next slide, please. So in every part of the country or the world, there are specific recommendation for vaccinations. So we have different recommendation in United States or in Europe or in Asia. And also these recommended vaccines depend also on the season. Of course, in this season, there is more important to think of diseases transmitted airborne or who are favored by the cold weather. The next slide, please. So we are in the North Hemisphere. We are in the cold season. So the recommended vaccinations are right now for influenza. And this vaccine is an inactivated vaccine. This should be done annually. Of course, in people on immunosuppressive drugs, there always been concerns about this kind of people not being able to mount an adequate immune response because of the immunosuppressive drugs. But in fact, even using the standard doses for influenza will bring a notable benefit for people. And do not forget to vaccinate also those around you, so those around people with IBD, to create a barrier to block the virus to pass from one people to another. Also, we are using in IBD, and we are recommending the pneumococcal vaccine against the pneumococcal streptococcus. And we are using inactivated vaccines with several types. It depends also of the region. Usually this is done with the help of some booster doses. Weeks later or even years later, again, it depends on the region or on the country. And this vaccine can be used independent of the use of immunosuppressive. Not being a live vaccines, both influenza and pneumococcal vaccine can be used any time of the year, preferably at the start of the cold season, independent of the level of immunosuppression. Of course, even if these vaccines are not highly indicated in the cold season, I can also emphasize the need to vaccinate, please change the slide, against some very bad diseases, very contagious diseases, diseases with a high potential of evolution, like the hepatitis B vaccine. Again, this is a subunit vaccine, not with a live virus, which implies that the vaccine can be used independent of the immunosuppression level. Of course, in studies, it was shown that using an intensified or high-dose regimen will improve the response to the vaccination. I have to recommend the vaccine against the human papilloma virus for the cervical cancer, also possible during the immunosuppression. And the last vaccine on my list, it's the herpes zoster vaccination, and also vaccination usually done in childhood, like the mumps, measles, rubella, or varicella. These vaccines are live vaccines. These are special vaccines. They cannot be used during immunosuppression, but they should precede the start of the immunosuppressor with at least some weeks. For the herpes zoster, there has been some good news in the last years, because now we have also in some countries an inactivated vaccines. So this can also be used by people already on immunosuppression. Concerning some tips for people with IBD and the seasonal vaccination, just use common sense. Remember that you should be vaccinated. Ask your doctor to check together with you your vaccinal status. So even if you weren't vaccinated for varicella, you should be checked, preferably at the first moment of diagnosis of IBD, because before starting immunosuppressive drugs, the doctor should be able to correct your list of mandatory vaccines. So if you have questions.
A lot of information there, Dr. Martesco. If I was to ask, what would be the two top seasonal vaccinations for IBD patients, in your opinion?
The two top from the first slide. So, of course, the flu vaccine, influenza, you should have this vaccine also in standard people without comorbidities, with other diseases, but especially in people with IBD, independently of the existence of immunosuppressive or not. Do vaccinate at the start of each cold season in November or October, even in December, even later is better than not having a vaccination. And the second one is anti-pneumococcus, anti-streptococcus pneumoniae. But this vaccine is has a booster doses not so frequent. So you have only 2, 1, or 3 doses in your entire life. Please do vaccinate.
And you mentioned there that those around you should vaccinate. And we've had a question from one of our members that due to the uptake this year, there was 33% more people who wanted the seasonal flu vaccination. So a lot of patients now remain without vaccination. Have you come across that, or have you experienced that?
Of course. And of course, the problem is complex because it's that a lot of the problems are due to the existence of the vaccine, the problems in accessibility. So I know that a lot of countries, it's not a scientific information. I read it in the papers. A lot of countries increased their yearly demand of anti-flu vaccines. So in my country, in Romania, we have a continuous problem with the right amount of flu vaccine. And unfortunately, there is not a prioritization of for those in need more than for the others. So I think people with IBD don't have a protective legislation to help them getting this vaccine.
I just have two final questions, and just anybody watching, we will be sharing slides and more information on it, but I just have two final questions. A question again from a viewer. We're not able to develop Hep B antibodies when on biological drugs.
Yes, this is cited, and we know that some people are not mounting an adequate antibody response. Of course, I'm speaking about people on immunosuppressive therapy. For these people, especially in the case of hepatitis B, I told you some specialists are using an intensified regimen with higher doses. This is possible also for influenza. This is possible also for hepatitis B. Just ask your doctor, because there are not only scientific issues here, but also legal issues. And again, you should adapt from one country to another. But if you don't forget to check the effect on vaccination. So you should have an adequate level of antibodies at the end of your vaccination schedule.
And I've just one final question, and I know we're slightly over time, but don't worry, we will catch up. Do you think a voluntary lockdown in relation to the current pandemic that we're in the middle of, in addition to vaccinations, could help people that are on immunosuppressants, on steroids, just coming into the time of the season that we are in Europe?
A very interesting question. You know, I think we are enough locked down. We had enough lockdown for this year. Yeah. I'm living in a town which is locked down, and I have the opportunity of speaking with people in all over Europe. But this is only an exception. I don't think lockdown will solve these problems. Just use the regular standard protection measures of protection, and I think this will be enough. And regarding the drugs, you know what? 6 months ago, we were all scared about the effect of biologics on the rate of infection with SARS-CoV and the rate of developing a severe form of disease, of severe COVID. But right now, the trend is changing. We know that biologic will not influence the rate of contracting the infection, but they might influence the rate of getting a severe disease. So there are studies with biologic exactly to show that they might fight the severe disease. So who knows? Why to lock down? Just be optimistic and keep up the standard precautions.
Okay. Thank you very much, Dr. Matesco, and thank you very much for your time, and stay safe, and I hope you come out of lockdown soon as well. Thank you. So now we move on to just a short synopsis of a survey that we did within EFCCA in relation to concerns about vaccinations and seasonal vaccinations in relation to with IBD. And Mario's just going to bring up my slide. So we did a survey among our members, and the results were 22 countries. And you can see we asked a number of questions, but this comes down to the accessibility of seasonal vaccinations. So are they free in your country? And you can see that it was very close in relation to some are covered by the health system, and then some are only covered for elderly or at-risk groups. And when we looked at question number 2 was IBD included in the risk group? And thankfully for us as patients, yes, the blue square will show you that the majority of countries it was included. But again, you can see that there is a majority if on immunosuppressants, and that would be steroids or anything like that. So it's just some interesting data behind seasonal vaccinations. Next slide. And again, this looks at the end of October, and similar, a lot of our members have had issues with increased requests for seasonal vaccinations this year. And those in green had limited availability, and there was supply problems. The ones in blue, the countries in blue being Portugal, Finland, Germany, they had available vaccines as of the end of October. But I think as some members have already said that with the increase in demand, these numbers were changing on a rapid basis. But this was just to give an idea of some of our, I suppose, members' issues and concerns over seasonal vaccinations. So now I'm delighted to introduce Martha Torres. And Martha Torres is going to take us through the LUDA case study from Spain. And I was looking at this last night, actually. And it's a really interesting study and concept for patients to gain access to medication. So I'd like to welcome, Luis Martin is, oh, yeah, sorry, Martha has changed. So my apologies. My apologies, Martha. You're looking great today, and you've changed since I seen you earlier on. So my apologies. This is Luis Martin Lazaro, who is the CEO of LUDA.
Mm-hmm. Thank you so much, and thank you for the opportunity to address your federation. What I want to talk about is we tried here in Spain to come with a solution to the shortage medicines in general, but it comes to our mind that Crohn's and ulcerative colitis is one of the, at least in the European level, one of the most affected patients relating to the shortage of medicines. Can you put the next one, please? Thank you. What we're trying to solve? Let me talk from a Spanish perspective, and I will talk later to a European perspective. We have a very fragmented market here. We're very lucky. We have 22,000 pharmacies, which is a pharmacy for every 2,000 patients. That involves a lot of ability to get to one nearby, but a lot of lack of coordination. The lack of awareness of what other pharmacies has means that they are not able to access the medicines that they need, and they have a lot of inventory, a lot of different medicines, and it's a chaos. Okay, we have a lot of pharmacies, but they are totally uncoordinated, and it's very difficult to actually locate and coordinate, having such a huge amount of pharmacies, where to find Imurel, Salofalc, the actual medicines that the patient needs. Can you put next, please? So what we come with is a solution that is based just on software. We try to rely on people when we need it, but if software can solve a problem, people will use it. So what we came is a software that adapts to any software that the pharmacy is using to make the stock available, to manage their own pharmacy. So we adapt to all of them. It doesn't matter, because we came with a solution that understands human language and understands the barcodes and understands the European codes for medicines. Once we did that, it doesn't matter which system are they using. We put a surface on top of that system that the pharmacist allow to question. So we are allowed by the pharmacist to question: do you have this? Do you have Imurel? Do you have Salofalc? So by asking via software, we don't need to wait to the answer from a human being, and they say yes or no immediately, and we can locate the group of pharmacies, or if it's only one pharmacy nearby, because we geolocate the pharmacies that has the medicine. Once we locate the medicine, what we do is we notify the pharmacy that we selected that the client is going, either to pick it up straight to the pharmacy or to send someone or a last mile courier to get the medicine for them. Can you put the next one, please? So what we were able to do is, without making the pharmacist work harder or do anything different, we were able to help them provide a solution, a real one, to the shortage of medicines, and including, of course, the Crohn's disease medicines, in no time. They just have to type the name or the international code of the medicine, and they will get it. We were very, very straightforward in this solution. We have no publicity. We have no list of preference and suggestions, just straight an answer to the question. We did it very much Google-like, because so far it was intended to be used by pharmacists and doctors. What we have found is that most of the time, 99% of the time, we always find the medicine. No matter how difficult or how long the shortages have been, there is a solution. So what we were able to do that with our program is, whenever there is a shortage of medicines because there is no production of it, or any other variables that we suffer in the European Union, we're able to come with an elastic band that allows the patient to get the medicine because it is in the stock of the pharmacist, until the laboratory, the pharmaceutical company is able to produce more of that medicine. Can you put the next one, please? So in the test, because we have an aim to be a European company, of course. In the test that Spain could be for this European project that we're telling, this is a reality now in Spain. 99% of the time, the medicine was found. 7,800 patients that were looking for a medicine included on the shortage list that the Ministry of Health in Spain made, so not regular patients, patients that were looking for a medicine that is out of stock. Not by us, by the Ministry of Health, 7,800 found their medicines. This, if we extrapolate the data and making a rough number, could be 1.5 million people every year in the European Union. Could you put the next one, please? So right now, out of the 22,000 pharmacies in Spain, we have 1,200. Now it's a little bit bigger than when we did it because we have been successful in the last month. Now it's 1,500. So we are around 7% of the total market of Spain. And let's take a little bit the three. The pharmacists are really, really willing to help patients, even if it's with no money involved, or even if they cost money for them. So we find them very, very eager to adopt the system, and that's where our success has been. We have been facing a little bit more problem with part of the lobby. When you put a system that make completely transparent where medicines are and what the prices are, some people are not happy. The thing is that in 1 month, if the authorities or the health system decided, we can put every pharmacy on the map and no cost for the patient, zero extra cost for the patient because we don't charge anything from the patient. We're completely transparent on that. Every patient, no matter how remote or how small their village is, will find medication even if it's in a shortage. If there is a slightly chance that there is in a pharmacy, we will know it because we know that on real time. That can be done also in a European level. It's very clear on the markets with, let's say, Mediterranean pharmacy system like Greece, Italy, but it's also working in the UK and the systems that they have big chains of pharmacies. The thing here is we rely on patients to put pressure on authorities, on doctors, and on pharmacists to rely to develop the network of pharmacies. That's what we need. The only thing what we need is more pharmacies. If we do that, all the doctors and the pharmacists, and we are also developing, we are in a beta to give that to the patients too, because we are very not friendly now to the patients. We are like super simple, and that simplicity and not appealing look is not the perfect thing for the patient, but for the doctors and the pharmacists, we are 100% proved that we can solve shortage of any medicine, and including, of course, Crohn's and ulcerative colitis. And again, the most important part that I want to stress is we decide that there will be no cost on patients. The implementation of this depends only on how much pressure the patients put to this system to be widely accepted. And I want to make it very short. I don't know if the system will allow us later to make an example of the system. If you were later on the questions time, if you want to see it, I will be pleased to try. I don't know if the technicality of the conference call will allow it, but I will be pleased to show you how it works.
Thank you very much, Luis. It's a fascinating system. And I suppose one question I had when I looked at it last night was, what is your data showing on the age profile of people using it?
Sorry, again?
What is the age profile of people that are using it?
It's right now the age is the pharmacist. The system is mainly...
okay.
So it's the age of the pharmacist, which is I don't know, 50, 55-year-old woman in Spain. But we did a beta for the patients. We released it just to see how it was. And we found that it's very easy to use for pharmacists and doctors. For patients, not so much. So we're like this Christmas, we will release a version for more user-friendly that didn't to be super efficient. So far, it's only been used by pharmacists and doctors.
Okay. And how has the reaction been with the pharmacists and the doctors? Have you had negativity, or is it just very positive?
Yeah, I don't want to brag about it, but quite positive. Actually, it renewed my faith on humanity because after dealing with politics, and because I'm right now with the COVID thing, I'm very, very much with politics all day, and that really not encouraged. I'm from the private sector, and I don't see how COVID is not so self-evident to everybody. But on the other side, pharmacists, they adopt the system. Even they are losing time to send someone to other pharmacies because they know they will help the patient. And actually, the patient came back to them to thank them. And we have a ton of emails explaining, like, I'm not only not losing my patient, he or she came back to say, wow, thank you. This is amazing. I've been wandering for like 20 pharmacies, and you point me exactly where it is, and it was waiting for me. And the doctors is the same. We are now encouraging them to put on Twitter, please, if you find the medicine through us, say it. So the head of cardiology, the head of, because it's not only for Crohn's, obviously, the head of cardiology, the head of the biggest hospital in Spain, which is La Paz, and Ruber, private clinics, everyone is posting on Twitter, okay, guys, just for you to know, this exists. I don't know why it's not mandatory, but exists. It has no cost for the patient. Use it.
How, and I'm going to ask this question, how do you plan on rolling it out around Europe?
How do we plan to roll it? Okay.
Just a short answer on how you, I suppose, trying to,
Yeah, we decide that the simplest way to do it will be like Portugal, Italy, Greece, Poland. They have exactly the same system. And there is a Pareto rule in which they have very little, like 5-6 software systems that rule all the pharmacists. So it's quite kind of easy for us because we already make the big job, which is unifying the stock, the names, the codes, and everything. So that will be easier, and it's very easy to implement. And the next step will be try to get to the systems where they allow change of pharmacies, but this implies more a negotiation with the change. So that will be the second step.
Okay, very interesting. I can't wait. If there's any other questions, do pop them in. We're just running over time, which anybody who knows me again is always my problem, and that we always run over when I speak. Is there any other questions to come in? No, I don't think there is. We will. I would like to thank all of our speakers today, and thank you very much for your time. I know it's very, very busy. I know live webinars have become part of our life, but it's still an extremely busy time with them. I would like to thank everybody who has been watching. I wish everybody to stay safe and well. If I am not speaking to you beforehand, to have a lovely Christmas, and look forward to hosting another EFCCA patient talks as soon as possible. Stay safe and well. Thank you.